The broadcast is now starting. All attendees are in listen-only mode.
Good morning and Happy New Year, everyone, and welcome to our January 6th Safe and Calm webinar. We hope that everyone has had a safe and calm holiday, and I know that we all look forward to a better year in 2021. This is Deanna Mitchell with Leading Age Michigan. This morning, our agenda is rather full. We're going to start with a discussion of our webinar schedule for 2021 and follow with our usual advocacy update. This morning, we have the pleasure to welcome several members who have already experienced their first vaccination clinic, and they are with us this morning to share helpful tips that might help members who've not had their clinics yet to have a smooth operation and process. We'll also take a quick look at the improving Michigan numbers, and then we'll finish with our usual updates. Starting this week, we're going to be holding only one webinar per week, and that will be our Wednesday webinar held Wednesday mornings at 10 a.m. We will continue to be responsive to member questions as they arise, and we encourage members to do that and also share information on our listservs. You can also use our Safe and Calm email address. We, of course, will respond to any direct emails that we get. We want to continue to keep everyone apprised of what's happening through our listservs, and we will be sending out probably a few more COVID member updates in lieu of having two webinars. So if there's anyone who isn't on our sign up list for member updates or listservs, please let us know. You can email either myself, Dalton, or Blake. So with that, we'll turn the presentation over to Dalton Herbal, our Director for Public Policy, who will discuss what the governor's been doing this week.
Good morning, everyone, and thank you for tuning in today, and Happy New Year. We do have a couple of updates about what's been going on this week, as it's been pretty jam-packed for not having a legislature in Michigan right now. Also, I'll just be reviewing just what happened with the budget, just to make sure everyone knows that the $2 an hour direct care worker wage increase pay was extended through the end of February. So what is currently going on in Lansing now today? As I said, Michigan doesn't have a legislature, but they'll begin next week. They'll have their first official day of legislative session on the 13th. In the meantime, over the last week, the governor's office has been working on reviewing bills from the last legislative session. As you may know, when the governor gets a bill, she has 14 days to sign that bill without it getting vetoed. Since we don't have a legislature, the legislature can't go back and resubmit that bill right now. So that effectively gives the governor the power known as a pocket veto during this time frame when the old legislature ends, but before the new legislature begins. And so we saw her yesterday and the day before, really, is when a majority of these bills were pocket vetoed. She did veto a couple of the bills we were monitoring outright, and she also signed some of them, and we'll cover those on the next slide. Before we get to those bills, let's just talk about the budget a little bit. I know you may have heard that she did some line item vetoes in the budget, but those were largely about unemployment dollars and some other dollars in there that don't really affect long-term care, and healthcare dollars remains largely untouched except for some special interest projects that she vetoed out of there. This leaves us with $103 million for vaccination, testing, and COVID-19 response efforts, $100 million to extend the $2 an hour direct care worker wage increase until the end of February, and $2 million to extend the $200 per day enhanced payment for CRCs also until the end of February. And I just wanted to note, for those of you who may not have had a chance to register yet, tomorrow Plant Moran will be doing a review of the state and national budget, during our Finance and Strategy Series session tomorrow. So if you're interested, please go ahead and register for that. So now we're going to move on to the bills and what's kind of happened over the last week and a half. The governor directly vetoed two bills that we've been talking about on our calls here. Firstly, she vetoed Senate Bill 1185, which would have extended healthcare, the legal immunity protections for healthcare facilities for a longer period during the pandemic, and also added CRCs to the definition of a healthcare facility. This bill had previously passed the legislature along party lines. So the Republicans voted for it with some abstaining and opposing votes from Democratic lawmakers. But throughout the process, the trial attorney groups fought very hard to get this legislation vetoed or changed because of some of the legal protections in there that it afforded healthcare providers. But the governor outright vetoed that. So we'll see what happens in the next legislative session and if a similar bill gets reintroduced. Right now, the legislature's really kind of just setting up their structure for next week. So they're not really making any kind of calls or saying anything regarding potential legislation. Another bill that I know some people were watching is House Bill 491 and 4910 and 4911, which is the Misrepresentation of Emotional Support Animals Act. That bill is also vetoed. That bill would have created flexibilities for housing and independent living providers regarding support animals and their use in their buildings. So now we get to the pocket veto section, which is where the governor just didn't respond to these bills, and so they essentially just go into the void or have died. So the Senate Bill 77, which is the electronic monitoring bill in SNFs, had previously passed with bipartisan support. So both parties supported the bill in the legislature, but the governor didn't sign it within the 14 days. So now it is effectively vetoed, and the bill will have to be reintroduced next session. Previously to the legislature leaving town for the year / the new one coming in, the bill sponsor already said that he'd like to continue to push on this front. So we do expect similar legislation to exist in the new legislature. The next bill that was just pocket vetoed, its timer ran out this morning, was House Bill 4098, which would have allowed for the use of medication aids in SNFs. This bill has been struggling for years to get across the finish line, as you know, and traditionally labor groups have opposed this legislation. We haven't heard from the governor's office why she didn't sign it, but we do suspect that it's kind of the same arguments that have been going on for years. The last bill I wanted to mention in the pocket veto was House Bill 4042, which would have added Michigan to the nursing or National Nurse Licensure Compact. This bill previously passed the legislature with bipartisan support, but once again, traditionally, this bill's been around for a long time, and labor groups have opposed it every time. Governor didn't comment on this because she doesn't have to offer comment on pocket vetoes, but we do expect this bill to appear again, like it does almost every year or every session. And then lastly, some good news. We have some signed bills that got signed over the last 2 weeks over the holidays. Firstly, Senate Bill 1021 creates license reciprocity for individuals who are educated in Canada. So anyone who was received a bachelor's degree in Canada, that now counts towards your licensure requirements. So if you're looking to hire someone from Canada, there's some good news there. House Bill 4491 would change the licensure requirements relating to good moral character standards, making it so that only felonies would be reviewed upon licensure application. So this does have some impact on those of our employees and team members and staff who are all licensed, or looking to be licensed. So that's kind of exciting there as well. So these were both signed and are going into effect, I think, within the next couple of weeks. And lastly, just our kind of roundup of important dates to remember. The next one is that the 31st is kind of the national government's deadline that they said that they plan to get the third round of PRF funds distributed to facilities by. I've heard that many people have already received these, but please know that if you haven't received them, that the deadline they set was the 31st for themselves. So they will be on their way.
All right, thank you very much, Dalton. Before we get into any questions, I did just want to touch on something that Dalton briefly spoke about, and that is our Finance and Strategy Day, or I guess I would call it a Finance and Strategy Series. That is beginning tomorrow, so if you haven't registered, feel free to go hop over and register. I'll just pull up our website here really quick. If you just head to our website, you can click on this events tab right here. It's going to be the very first day that you see here, and you can go ahead and register if you are interested in that. We do have a lot of great content. I believe tomorrow, January 7th, we will be hosting our friends from Plant Moran, MISTA, HUD, and Therapy Management. And this information pack day is one you will not want to miss. Be prepared to be briefed on an overview of the current reimbursement landscape in Michigan, covering Medicaid, Medicare, and managed care, financial and strategic approaches to therapy services covered under Med B, elderly housing, and so much more. And then we will also have the second portion of our Finance and Strategy Day on January 27th. So we will open day 2 of our Finance and Strategy Day on January 21st with our friends from Ziegler and a panel discussion by Leading Age Michigan members. This half-day session will focus on strategic trends in the senior living and care sector within a framework of the national economy, the capital lending environment, and aging services climate nationally and in the state of Michigan. So a lot of information that I think could be very helpful. So go on over to the Leading Age Michigan website and register for that today. At this point, we do not have any advocacy questions, so we can go ahead and move forward.
Thank you, everyone.
Thank you, Dalton. So we're now going to turn our presentation over to some of our members who have recently held their first clinic to share some of their experiences with us. This morning, we'd like to welcome Libby Delady from Bellbrook, Barb Giles from Jewish Senior Life, Paul Barber from Heritage Community of Kalamazoo, and Kristen Packard from Grand Traverse Pavilion. So let's start with Libby and the experience that they've had at Bellbrook.
Hi, good morning. Thank you for having me on the call. We did have our first clinic on December 28th. CVS was our provider. We were there first, they were ours. So we did have a few hiccups, but we successfully vaccinated 252 people on our first day. We did 183 residents and 69 colleagues. We were fortunate to do whole house. We are a life plan campus, so we have independent living, 2 adult foster care licenses, a HFA license, and a skilled license. And some of the things that I would like to share that were very helpful for us is we paid very close attention to the CVS guidebook that they gave us to try to be as organized and prepared as possible. It's very important to be ready with all of your leadership team. It is 100% an all hands on deck event. We had all of the copies and individual file folders for all residents with insurance cards front and back, prescription cards front and back, and all of the consents ready to go. The health center areas do take the longest because for this campus, they did go room to room for that. So when you are done with the health center and ready to go into a full clinic mode, we had that set up in a large space with 2 clinics in a waiting space, socially distanced, where we would check in and kind of get everybody there, including our staff. So we always had a line ready to go. For the independent apartment residents, We also took them down to our restaurant space and had them all spaced out in there with snacks and water after for an observation room for the recommended 15 to 20 minutes. And, you know, I think it's overall, it's an incredibly exciting day. It's a lot of work. I think that the team that we had here to work with us, they were wonderful. They were very willing to help. And they just kind of, we guided the process, worked with them and got them what they needed to execute as many as they could in a small window of time. And I don't know, it was very exciting, and I'm very glad that it's over, and our next date is the 25th.
Hi, this is Barb Giles at Jewish Senior Life, and our first clinic was on the 4th, and at that clinic we did our 3 licensed adult foster care homes that are embedded in one of our communities, and a HUD 202 independent living community, and our pharmacy is CVS. Prior to your clinic, I would recommend that whoever is your point person know that they need to answer spam calls on your cell phone. It is the pharmacy calling to confirm. You will, if you don't answer your spam calls, you will miss your confirmation call accidentally because you think it's spam. It comes up as spam on your cell phone. I also think you might want to be aware that I got multiple calls to confirm the clinics even after I had confirmed them all, as many as 5 calls to confirm the same clinic. And it is a little disconcerting because you already think you're confirmed and they keep confirming. But it seems like if any information is forgotten in the database when they enter it, they just continue to call. If you do have access to the CVS website to confirm, as of now, I would not recommend using it because it did not work. I did not receive any confirmations through that system after I waited the allotted 24 or 48 hours. The only way I was actually able to confirm our clinics was by calling the confirmation number. Your clinics will most likely not be assigned to one single CVS local pharmacy. Of our 7 communities that are having clinics, we have 4 different CVS pharmacies that have been assigned to us. So I would make sure that you, after you even have your confirmation, on your confirmation, you will have the phone number to the local pharmacy that you have been assigned to. And I did not wait for them to call me. I proactively called them to collaborate and make sure that we had all of our details, because this is your clinic and you want it to run smoothly. And that person really is your point person for the day who will help you the most. I did find that when I had that number, I would call the local pharmacy, then you have to ask for the pharmacist, and then ask for the pharmacy manager, and then ask to speak to the person who's assigned to your clinic. And this often takes multiple calls to get to the right person. But your persistence will pay off because it really does help to build a great clinic day. And then 24 hours before the clinic, we actually called that person with our exact number, so the proper amount was defrosted, because we really feel very conscientious about not having any overage in the defrost. So then on the day of the clinic, you'll need multiple stations. In addition to the ones that are listed on the CVS website, you need that registration. You'll need a registration table, whatever inoculation stations that they tell you they will be doing, and then the recovery area. Again, as Libby said, this is all hands on deck. You will need multiple staff members involved. In the registration area, you for sure need at least one staff member who knows the staff and residents at the station. You'll be wanting to monitor your spreadsheet. You'll want a second staff member to help expedite people to the inoculation stations and keep track of your spreadsheet. At the inoculation stations, we used our own privacy dividers, which I thought was a very nice addition between each station for people who were not wearing short sleeve shirts. Again, because in independent living, they're not going door to door. and we had a lot of people who needed a little bit of privacy. We ended up supplying some cotton balls because the pharmacy did not recall to bring those. So when people had some bleeding, we brought some cotton balls over. And you'll need lots and lots of wipes for cleaning and wipe down between the residents. You will have to remind the pharmacist that the station has to be wiped down every time between the residents, and you will need to be monitoring them to make sure they're doing it because it's often forgotten. And so we always had an eye to make sure that we were making sure all the stations were getting wiped down between each person. In recovery, I recommend that you have at least 3 staff members to monitor time, snacks, and sanitization. We used a sticky note process that when each person moved into recovery, they were given a sticky note with their 15-minute time so that we could sort of keep track when somebody was done. We also gave snacks and fruit and water in that area. And I would also suggest you might want to consider having the consent form for round 2 available for people to fill out then. So you can get that filled out during round 1, so you have them ready for round 2, because you will need a second set of consent forms, is what I understand from CVS for the second round. Again, you will need lots and lots of sanitization wipes. For every time a resident moves, you got to re-sanitize that area. Make sure that you know people need to save theirs in independent living. They need to save that CDC card that they're given. And I would also recommend having a social worker or RSC available in recovery, because we did have a few people who needed a little bit of support while they were waiting. And also make sure, I know I'm running out of time, I want to make sure you guys know that you want to have your that V-Safe information available to give out to staff to register for V-Safe when they're done. And more information just at recovery, because we found the residents just did not know a lot of information about recovery. And I will send a CDC sheet to Deanna that gave more information on what to expect in the next 24 hours in case anyone has issues. I also recommend you'll need some paper clips and pens. They just did not have that kind of stuff. You'll need blank consent forms. We provided lunch to the pharmacy. And then the next day, you will really want to make sure that you do wellness checks on the residents in independent living the next day. We ended up, out of the 130 vaccines we gave, we had 3 staff members who had slight issues. And so you would also, we felt responsible to want to do wellness checks on the residents the next day. I would just, it's a super exciting day, as Libby said. And also, just so you know, you might probably keep about 10 to 12 residents in the waiting area to bring into the room for when you're ready. I think I have used my 5 minutes, so I don't want to go over. Perhaps Paul or Kristen will cover other topics that perhaps I forgot. Thank you.
Thank you, Barb. Hi, this is Paul Barber from Heritage Community of Kalamazoo. And we also partnered with CVS for our first round, and those are currently underway this week. We are a continuum of care retirement community, and we actually have 4 separate clinics on campus this week, 1 in skilled nursing, 1 in memory care, and then 1 in each of our assisted living communities. And our second and third round clinics have already been scheduled, of course, for 28 days after. And we're really pleased to have our clinics scheduled in that way. The first 2 clinics on campus have gone really well, and probably the most important point I would share is that we've had to be flexible and responsive as the situation has developed. Things have changed over the course of setting up our vaccine clinics, and we've approached, of course, the pandemic in this way, and our clinics are no different. I think Libby referred to the CVS guidebook, and we followed that very closely, but unfortunately our timeframes really crunched down. We didn't have the triplicate forms well in advance, and so we were using the copied consent forms. Also, the online consent form updated on the CVS website, so we had to make sure that staff knew that either consent forms could be used, so we didn't have to continue to duplicate our consent forms. Additionally, when in one of our clinics, when the pharmacist arrived, the pharmacist was initially insisting that we transfer all of those copied consent forms onto the triplicate forms, and we were able to reference the CVS guidance, and so we didn't have to redo that information. We originally anticipated receiving the Pfizer vaccine, and we were told late last week that we were actually going to be receiving the Moderna vaccine. And one key piece of that is the Pfizer vaccine had an emergency use authorization for people 16 and older. So we had originally received consents for our younger employees who were under 18. And after reviewing the Moderna emergency use authorization, it was evident that Moderna was authorized for people 18 and over. So we've gone back and made sure that no any of our people under 18 are not receiving the vaccine at this point in time. Very similarly to what Libby and Barb were saying, we pre-planned the flow of people in our locations, and definitely you will need to have additional support individuals to help handle the consent forms and monitor your staff and residents following their vaccines. And I'm just kind of scanning through my notes here, not to duplicate any points that were already made. I think lastly, I would share a fun point. To promote the vaccine, we've started a campaign called I Vaccinate to Crush COVID-19 to encourage our residents and staff to receive the vaccine. And of course, we provide a lot of information and access to that information. But with this campaign, we've had signs printed, and we set up a selfie station at each one of our clinics, and the staff are taking pictures. We printed stickers that say I vaccinated for, and you can put your mom or your residents or whatever in there. We've had a really positive response, and we've already seen staff posting their own pictures online, which I think is really great. All in all, we're very grateful for the opportunity to vaccinate our staff and residents, and happily working through these challenges as they come. I think great points so far today. Thank you.
Hi, this is Kristen from Grand Traverse Pavilions. Our clinics are underway as well, and very similar experiences to what everyone else has mentioned. For residents, we've done 178 residents, which is about 93% of our population. And then for staff, we're working on staff today and tomorrow. We've got about 215 that we expect to do. Or no, I'm sorry, those numbers are reversed. 215 residents, 178 staff members. So that's about 55% of our staff and 93% of our residents. So overall, pretty good turnout. We've got a lot of people turning in consents, signing up for the second clinic, which we know will be the first week of February. On day one, we started with the residents, and we went mobile day one. So we did our memory care unit and then also our rehab floor, because that's our designated isolation floor. So we wanted to get those people out of the way, did that, and then moved to the multi-purpose room where we started bringing people down. Very similar setup as everyone else has mentioned, where the residents are in a line, you circle them through. We've divided all of their paperwork by the pavilion that they live on, and then alphabetized it. So very easy to get the paperwork out. We were told by Walgreens that we could complete the insurance information on the consent, which we have now started making copies of all of the insurance cards, because after day one, there was a few issues with S's and 5s getting mixed up, zeros and O's getting mixed up, things like that. So for the staff, we've asked them all to bring a copy of their insurance card, and we're just making a copy and attaching it to their VAR. Our pharmacy has asked for temps on everybody prior to administering the immunization. So we brought a roster with everyone's name on it, put their temp on it, had that taken before they came down. That was fine. We asked the staff to make sure that all of their arms were accessible with their clothing, that it could either be unbuttoned or pulled up or whatever. That's went pretty well. On day one, we had a lot of the consents not have section B1 completed, so we had to go back through and do that. So that's one thing that I do recommend, because it did slow us down a little bit in the beginning. We kept pulling VARs and they didn't have that section completed. So we ended up pulling them all, sent them all back to the nurses, had them all completed, and brought them back down. We had an unfortunate incident on day 1 too. We had a pharmacist and a pharmacy tech, and the pharmacy tech, we were on our second pavilion, so still very early in the day, and she had a needle stick. So we lost her for the rest of the day. She was on the phone with Walgreens for quite a long time, and then she had to go get labs drawn. And after that, she was pretty shooken up. So when she came back, she just worked on paperwork. But Walgreens was great. They sent in somebody as soon as they could, and we've had somebody else for the remainder of the week. So still 2 people doing the administration. I don't think I have anything else to add.
Well, thank you, Libby, and thank you, everyone. I think this has been a great Yes, hello?
I just remembered something sort of important that I wanted to say for independent living or 202s when you get to them. Many of our residents still had their old Medicare card with their Social Security number, and they've been issued new Medicare cards. Many of them have not updated their Medicare card and still are using their old number. So you really will want to audit through those because they accidentally have not really realized that their Medicare numbers changed. So that is something you will want to get on top of early, since some of them don't change out what's in their wallet. So I just wanted to mention that.
Great, thank you, Barb. And thank you, everyone. We're going to pause now and see if there are any questions for our members.
All right, thank you, Deanna. We do have a couple questions, so I'm not necessarily sure. Obviously, if one of you 4 know the answer, then feel free to answer it. How are IL and HUD receiving access to the vaccine when the MDHHS plan clearly states that they are not included in Priority Group 1A, and McKnight's published an article today with CVS stating they are not vaccinating IL residents?
Deanna, do you want to answer that?
Do you have an answer, Barb?
Well, my answer is I did participate in an MDHHS webinar where it was made clear on a handout that there are some ILs and 202s that were selected to participate. And that was the information that we had. And that was from an MDHHS webinar. I think I did send that copy of that slide over to Deanna. Of course, we did not determine when we were getting done. We just received the call that it was our turn, and we clearly disclosed what our identifications were of our buildings.
This is Deanna. What I've heard is, this is extremely messy. There's no question about that. We've heard different stories from different groups, but from officially from the pharmacies, they will tell you that independent living is not included at this point, at this stage in Michigan. However, CMS and HHS have also stated, along with the CDC, that there are some independent living and Section 202 housing areas that are in the higher priority. However, no one knows what the criteria are for that, or even if that's really true. So we know that some of the pharmacies are vaccinating some of the independent living, and they're not doing the others. And we don't have a good answer for that. We just suggest that everyone keep trying and working to get all of their consumers vaccinated.
Okay. I did have just a comment from somebody who said our IL residents were vaccinated with dose number 1 by our county health department on December 30. But I do have a couple more questions. For buildings that already did residents, how did you document in the EMAR that they received the COVID vaccine?
We had, this is Kristen at the pavilions. We haven't documented in the MAR yet, so Walgreens will put it into MICR, and then our process, as of a couple months ago, has been to just have somebody print off the MICR sheet when residents are going to the hospital or when they're discharging and going back to their PCP. So we're not really using our MAR for immunization records anymore.
This is Libby from Bellbrook, and so for our EMR for the nursing home, we did have an order in Vision is what we use, and then it had the physical monitors attached to that we put in, and then we did also put it in QuickMar for the HFA and AFC licensed areas. We also scanned in the consents and of course had the physician orders.
Okay. Yeah, someone said PCC has an integrated way to document vaccination. So I believe that you might have touched on that as well. We plan to have pharmacists go room to room. Has anyone else done it this way? If so, what were your results?
This is Libby again. We did do it room to room for the health center areas. I mean, the results were great. The process was slow. So we had a pharmacy person with a clinical leader to go room to room. They had a cart with all of their supplies, appropriate PPE, all the consents ready to go, the questions filled out. The immunizer did take the temperature of every resident, and then they would just administer the immunization. So it just takes a little bit longer.
Okay, I believe this question is going to be for you as well, Libby. Did CVS vaccinate all residents at Bellbrook, including IL, or only SNF, AL, and MC?
So we were fortunate that we were able to get our whole house residents and colleagues through the our first initial vaccine day, and I believe it was Barb had mentioned, you know, when you get your call and you talk to your person, you talk about your total number that you're hoping to do of vaccines. And so I did communicate that from the beginning. We are a campus, so I don't know if that is part of why we were able to get our whole house done on the first day. I have heard from our local health department that they are working on ILs in our area. And I have some colleagues that work in ILs that are getting done in the area as well. So I don't know, again, how that phases out, but we are all under one roof. So perhaps that's why we were able to get it all done on the initial day.
Thank you. Just curious, the percentage of residents and staff that participated, heard 93% and 55% from the last presenter, and wondered if others had similar experience.
I'll just keep talking. We had pretty much every resident chose to be vaccinated. So it was there were a few that, you know, rehab in and out of the hospital that, you know, wanted to wait till the next phase, or, you know, just a couple one-offs, but pretty much every resident wanted to be vaccinated on our campus. And then if I'm running some quick numbers on colleagues, I'd say we're close to around 60% of our colleagues.
This is Barb. I think it will vary greatly from community to community, because the community that we vaccinated has a high percentage of people from the former Soviet Union who certainly have some historical concerns of government and possibility of, you know, whatever might be going on. So I do think it'll vary from community to community. But we are also hoping, as far as our staff participation, that we pick staff up also in round 2. You can get vaccine 1 in round 2. And we're hoping to continue to build confidence in staff members who were on the fence for this early clinic on the 4th, because we have more clinics on 12, 13, 14, and 15. And then they'll be back in 28 days. And we are hearing from staff that might decline round 1, but might join us in round 2 after they see the round 1 people doing well.
Thank you. It was our understanding the pharmacy would be responsible to follow patients who discharge from us to get their second dose. CVS told us they will not be doing this and are not allowed to vaccinate outside of the clinics, and that they would need to come back to our campus on the day of the second dose clinic. So I believe.
CVS actually produces a document. It's part of their guidebook. In there, it's a return to vaccinate type form. I'm sure that's not what it's called, but there's a form that you can give. So, for example, to your rehab residents that received it round 1 that may potentially not be there for round 2, it tells them the date of the clinic and then invites them back to the building for that day. I do believe that that is correct, that it is the building and or resident responsibility to follow up to get them back for the second dose, and not something that CVS is taking on.
Also on the CDC card that the resident is given, the reminder date is on the back of that CDC card, reminding them when their return clinic date will be.
Okay. And then someone said, in our communication with MDHHS, CVS recognized the importance of vaccinating the entire campus. The advice is to be sure the correct number of doses are prepared in advance is sage advice. Okay, so at this point, it actually looks like we do not have any more questions or comments, so we can go ahead and move forward. Deanna, I don't know how you would like to proceed. Actually, no, we just had one other comment come up. I'm sorry. We had great success doing an education session with our staff. We did live Zoom sessions and also recorded it and sent out to all staff. Also sent weekly reminders of the vaccine clinic and created hype. We had over 200 team members show up.
Great. Well, I think we've learned a lot here this morning, and we want to thank all of our members for sharing their experiences. We certainly hope that the vaccinations keep being distributed and can turn the tide here in the next few months. So again, thank you. And if you have other questions or comments, please feel free to use our email address, and we'll try to answer as best we can. So let's now move on to our Michigan update. We're going to go through this rather quickly just to give everyone kind of a summary of what's going on. We will start with our routine Michigan update. And you can see from this graph, we're encouraged by the rapidly decreasing daily caseload that's been occurring since late November. Although there has been a slight uptick during the past week. We're hoping that it's actually going to level off again, and of course everyone is closely monitoring that. In terms of deaths, again, we've seen a sharp decrease over the past several weeks, and again with a very slight uptick. We did have a large number of deaths over the past 24 hours, and that's affected the numbers a little bit, but it does look like at this point at least it's leveling off. When we look at the Cms positivity rates, you can see that there's been a marked shift in the number of counties at the red or high transmission level, 10% positivity rates and higher. And those numbers have, those counties actually have now moved to more green and yellow risk levels. This data is current as of 12/30. However, using the MDHHS Safe Start map, all but 7 counties continue to be at level E. And we do know that that continues to affect our ability to have visitation. So we're watching those counties, and we're hoping that they start to move to lower alphabet letters soon. Looking at the MDHHS data on SNF weekly caseload, we can see continued declines through January 4. Although the rate of decline may be slowing a bit, but it is very positive. It's less clear what's going on with HFAs. The data seems to be going, the numbers seem to be going up and down a bit, but there was a slight decline since last week, so that is also a good sign. For AFCs, we saw a very slight increase from last week, but it's so slight that it might just be a leveling off from higher caseloads that peaked in mid-December. So we hope that this is going to continue to be encouraging as well. Here's the table that includes pretty much all the numbers for long-term care facilities here in Michigan. You can see that there's a total of about 40,000 cases across long-term care facilities for both residents and including staff, and a total of about 4,700 deaths. We have seen a slight uptick in staff deaths after a long period of many months where we saw no new staff deaths. So we are seeing some increases there, unfortunately. So we pulled this data from NIC, and it's current only to mid-December, but we thought it was kind of interesting. This graph displays the percent of nursing home residents who were new cases each week since June. So you can see that we peaked in early December nationally, and the numbers are just starting to trend downward. This slide, which is also a NIC graphic, identifies the national trends in SNF occupancy. You can see that as of mid-December, the average occupancy fell nationally to 69.3%. That is pretty low. I think that's the lowest I've ever seen it in my history. At this point, we'll move on to our updates before we take more questions, and we are going to continue on with some updates about vaccinations. So we just wanted to note that in late December here, MDHHS changed its vaccine priorities just a bit. The path for getting long-term care facility residents and staff and the priorities for that have not changed. And we know that there's still a lot of confusion about how some of the independent living communities are getting vaccinated. But the state did move persons over the age 75 toward the top of the list. And you can see that they have moved up to Group 1B. We are still basically at Phase 1A, and we'll be waiting to hear what the plans are for distributing vaccines to adults older than 75 in the general community, as well as perhaps in our senior independent communities as well. But we did hear from our speakers this morning that the county health departments have started to work with some of the standalone independent living facilities, and so that's a very good sign. Looking at where we are in Michigan, unfortunately, compared to other states, we seem to be lagging in distribution. They note that there are additional vaccine products in the testing phase, but the analysis shows that the slow rollout in Michigan is more due to bottlenecks in distribution rather than manufacturing. To be honest, we're not sure what those bottlenecks actually are, but we do know that our numbers are lower in terms of the numbers of vaccines we've been able to distribute than a lot of other states. We also know that staff have been somewhat reluctant to accept the vaccine in some of our member facilities, but we also know that that's true in other states. Michigan, MDHHS reports that they anticipate that they will get to healthy Michigan population, which is the last phase, by April or May. And Dr. Fauci this morning reported that if that happens, if they can get the healthy Michigan, healthy population in general, vaccinated by April, May, and June, that we might be able to go back to a somewhat normal lifestyle by fall. The state is also monitoring to see if we will experience a surge related to the recent holidays, and we certainly hope those downward trends continue. The goal in Michigan is to get 80 to 90% of persons vaccinated in order to improve our risk levels and the safeguards that we have to apply. There is, of course, about a zillion websites with ongoing updates for vaccines. We have included several links for pages that we've been using. Leading Age keeps an updated FAQ document, and they've also developed in the last week or so an FAQ document that is specific to affordable housing. And both of those links are here at the top of the slides. During this week, the CDC has also updated guidance on each of the vaccine products currently being distributed, Moderna and Pfizer, and they've also updated a page on the clinical considerations that need to be taken regarding those vaccines. They also held a program last week for clinicians and included information about safe use of the vaccines, potential side effects, etc. The link to all of that the links are here, along with more information from the CDC about recommendations for dealing with allergic reactions. And finally, we have included the link to the state MDHHS list of confirmed long-term care clinic dates. HUD has created a Q&A document related to COVID in general, and this included, it was updated in the past, this week actually, past couple days, and it included some information on vaccines as well. Unfortunately, you know, the answers about housing and independent living settings and getting vaccinated still is fuzzy and confusing. And Leading Age felt that this Q&A fell far short in answering the questions that they had about distribution for those settings. The Q&A also confirms that the eviction moratorium has been extended to January, and other reviews and assessments will continue to be delayed. And of course, the link is at the bottom of the page. Before we pause again for some more questions, we do want to briefly review the use of monoclonal antibodies for treatment of COVID persons. The criteria are you have to be at least age 12 and at high risk for progressing to severe COVID symptoms or hospitalization. So monoclonal antibodies are produced chemically. They are not antibodies from another person, but they are produced, and this treatment has been authorized under the emergency authorization by the FDA only for this purpose, to keep people out of the hospital and to reduce the symptoms and the progress of the disease in persons who are high risk. So the antibodies can be administered to persons who have tested positive, who have not been hospitalized, and who do not need oxygen or at least additional oxygen related to COVID. By the time the symptoms progress to the point where the persons need to be hospitalized, it seems it's too late to have any positive effect. And in fact, a lot of the literature says that administering the antibodies at that point may have a negative effect for persons who have significant breathing problems and need significant respiratory support. So the FDA guidance goes on to provide more detail about persons who are at high risk. Those details are listed here. Most of these criteria or conditions are not really a surprise to us. They are also the same conditions that we already know provide a higher risk for COVID outcomes, bad outcomes. The treatment is itself delivered by IV infusion, and there is detailed guidance from the FDA. And if you are preparing to provide monoclonal antibody treatment, we strongly suggest that you go through the entire guidance. But the general gist of it is here. So just like for our vaccines, there are numerous resources on monoclonal antibodies, and an additional list of possible resources are on this slide. Many of these resources were cited from a presentation that was provided by MDHHS in later December, and we're going to talk about that with our next slide a bit. So MDHHS has created Project Speed to assist in distributing, and they will also actually assist with administering monoclonal antibodies in non-hospital settings. The medication is totally funded by HHS, and at this point, MDHHS in Michigan here, they're poised to provide the treatment to SNFs who may be having a large outbreak within 24 hours of that outbreak. The department is responsible itself for allocating the treatment, the actual drug to any entity in the state. They have developed a mobile crisis team along with local paramedics who will be assisting. Members who want to use this treatment can request assistance through their local health coalition or public health agency. The links for the slides from the department presentation about this and other forms and information that you need to know are at the top of this slide. Okay, so let's pause for any questions that might be out there.
Okay, have a couple questions here. Anything about having pets back in for visits again?
Pets?
Yes, pets.
I'm not aware of any. I'm not aware of anything. We can kind of take a review of that, but I've not heard that that's allowed at this point.
Will there be any guidelines on the residents who have not received the vaccine?
The only thing that I'm aware of is that the vaccine administration itself doesn't change, at this point at least, the current safety precautions that have to be taken. So I would assume that those safety precautions would be the major piece that would protect persons who choose not to be vaccinated. We've not heard anything in particular that would come out in addition to that, but we do know that they're not going to really loosen some of the basic restrictions until they know that there's enough safety in doing so. If we hear, of course, of any guidance for non-vaccinated residents and or staff, we will certainly let you know, but I'm not aware of any.
If residents have received both COVID vaccines, do they still have to be placed in quarantine when admitted?
At this point, yes. There are no changes at all to the rules.
All right, as of right now, it looks like that is the last question.
Okay, so let's move on. These are a little bit more general updates. There is a second draw paycheck protection loan option that's now available for those who have received a first loan and continue to demonstrate a reduction in gross receipts. Leading Age has developed a informative document on that, and that is linked here. And we also know that mandatory paid sick leave and FMLA leave flexibilities, they ended December 31st. But recent legislation passed by Congress does allow providers to provide paid leave voluntarily for COVID-related reasons. And the link to the Leading Age summary document about that is located here as well. HHS has updated its Q&A document on provider relief funds. Basically, the update really is rather small. It talks about the fact that state funds must be expended on COVID expenses before using federal provider relief funds. And basically, the federal funds must be used as a payer of last resort. Apparently, some states were telling providers that they need to spend their CARES Act provider relief funds before using any other funds from the state. The link to the updated QA is at the bottom of the slide. So I put this slide in here just as kind of a reminder. This slide is a very broad summary of the CDC guidance for retirement communities and independent living. Oftentimes the CDC tells us that they've updated a page, and yet we can't really find what the essential changes are. So we summarized a lot of the content here, just the big picture items, but we didn't really see anything new or helpful that came from this guidance. Members might want to review the web page if you're a retirement or independent living community. The link is here. However, it actually looked pretty much the same to me. So for the next few minutes, we're going to talk about N95s, and this has been a controversial topic in Michigan for the last, well, perhaps the entire pandemic. The CDC updated its webpage on optimizing the use of N95s. There is some new information here. They speak to both the engineering and the administrative actions that can be taken to minimize risk. So obviously, anything that you do to decrease the risk of transmission should, in the long run, decrease your need for use of N95 masks. They also provided more information about limiting the use of N95s when training, allowing some reuse by the same individual for the mask that was used during training in order to extend some of the use. They also suggest that when doing fit testing to use that you use the qualitative methods because when you're doing fit testing and use the other methods, you're actually destroying the mask during the process. There's an awful lot of information and confusion about N95, so we strongly suggest that everyone review the guidance, and we have other guidance coming up as well. And the CDC update link is on the slide to the left. So the CDC identified that there are acceptable alternatives to N95 masks that have been approved by NIOSH, note that word, when N95s themselves are not available. So there are other products, other types of safety protection that are listed here. I'm not very familiar with them, and I'm not sure how practical they are. But they specifically say that if you can't use an N95, these other NIOSH-approved types of masks are acceptable. Another thing that they note is that if under contingency strategies, which means that's not normal time, but not crisis time either, and if there's an expected shortage, you can suspend annual fit testing per OSHA guidance, but they're only talking about annual here. So they also have provided a bit more detail in employing crisis strategies in order to maximize use. They do consider use of respirators that are similar to these NIOSH-approved respirators. And we find this a bit challenging because there are also rules apparently from MIOSHA that we're going to talk about in a minute that are confusing about the use of KN95s. But they do talk about the crisis strategies. And of course, in those times when there are severe availability issues, you can prioritize use by the type of activity planned, distance from the patient, use of source control by the patient. And again, that is when you know that you're not going to have enough N95s to go around, and you have to continue to document that. when there are absolutely no N95s available, they suggest that you exclude any staff who are at high risk for bad outcomes from COVID from providing direct care. And there are also apparently some products that I had actually never heard of, such as a ventilated headboard that decrease the risks of staff exposure during procedure, aerosol generating procedures. I think I have that written wrongly on the slide. I apologize for that. And we do encourage everyone to read this guidance. Again, the link is on the left. So there continues to be a lot of confusion about use of N95 masks in Michigan. We do know that the department still has guidance on its website that pretty much requires the use of N95s for all resident care in all resident settings. However, pretty much they themselves seem to be ignoring that guidance. In discussions with them, they do not seem to be supporting. We're talking about MDHHS here. They do not seem to be supporting the use of N95s for everyone. Mostly N95s have to be used for persons who are either COVID positive or COVID suspect. The recent guide from Laura for surveyors that identifies the set of scenarios and what needs to be, what the facility actions are for each scenario, states that N95s are needed only for COVID positive persons or COVID suspected persons and potentially exposed persons, nothing for your general everyday care. The department is working on and has been providing training and guidance for HFAs and AFCs. And in working with them through that training program, they've identified that a large number of AFCs across the state have not had access to or have been using N95s. And these facilities have been cited by MIOSHA for that. They're with this confusion around the differences between the MDHHS guidance, the LAURA guidance, and the MIOSHA guidance. Members still continue to be confused. So there's been some preliminary discussions with MIOSHA. And what they pretty much have said, and these are preliminary, they don't define the details here in any of their guidance to date, but they're not allowing the use of KN95s, even if approved by the FDA, as a replacement for N95s in all situations. They will allow them in lower level needs. And we're continuing to have discussions about the situations that KN95s can be used. So we don't have final answers from MIOSHA about this, but we're working on it. From what we can tell, they do require that N95s and not KN95s be used for aerosol generating procedures, and they require N95s themselves for COVID-related care. KN95s, at least as we understand it now, in their view, can only be used for non-COVID based care and those who have not been exposed. And it seems that they are requiring fit testing, but they suggest that to use only what they're calling test checks instead of a full fit testing if there are not enough testing kits available. But as I said before, this is what we're hearing. We have not finished these conversations with them, so I would expect more guidance to be coming in the future. MDHHS in recent weeks issued a directive that allows COVID relief facilities to suspend their 85% Medicaid occupancy rule for their dedicated units. In order to apply this rule, facilities must keep the department updated as to their dedicated unit bed capacity. So if that's changing at any time, you have to let them know immediately using their form. And I forgot to link that form here, so we will try and provide that in an update later. And of course, the flexibility for the 85% rule is only able to be applied if you have been approved to take external COVID admissions. If you are a facility, a COVID relief facility that's only retaining the 85% will not apply to you. And our last issue for today is that CMS this week issued QSO 2031. It loosens a little bit the triggers for an infection control survey in nursing homes. The added criteria, it's not well described in the memo, but they kind of added another piece of criteria that will be needed before it triggers an infection control survey. So it's 3 or more cases that are new within a week, or 1 new case in a facility that was COVID-free, and it along with at least one of the following: multiple weeks of new cases. I have no idea how many weeks that means. Low staffing. Again, we don't understand how low we're talking about here. So they really haven't detailed the pieces, but they have added this one additional criteria. So in essence, it'll be a tad harder to get an infection control survey, which, some of our members have had a lot of them. So we understand that could be a positive thing. Selection as a special focus facility, concerns related to conducting outbreak testing, allegations of abuse or quality issues at a high level. So all of those things are something that has to occur along with the cases that we talk about above. The actual survey is meant to be conducted within 3 to 5 days of identification. They do finally say that if you've been surveyed in the past 3 weeks, they won't necessarily come in and do another survey. So that's a relief as well. I'm not sure if that's really true, if there's complaints related to abuse or quality issues, but they do identify that they are intending not to survey more than once every 3 weeks. There's a long list of enhanced enforcements. They're still in place, but they've not been updated. There is a large section of new FAQs. And so we suggest that nursing homes really look at those. But basically, they're saying that surveys will continue even though there's an outbreak. COVID positive residents are going to be interviewed by surveyors. CMS does not anticipate mandating surveyor training, although they recommend it. And they spend a lot of time talking about the survey and how they will reflect the 1135 blanket waivers. So if you're a nursing home, you've not read this guidance yet, we suggest that you do so very soon. Okay, so that was an awful lot today. We appreciate your continued participation. Any final questions, Blake?
All right, we do have a few final questions, but before we get to those questions, I did just want to give a quick reminder because I know we've had some people join since Deanna mentioned it earlier. Moving forward for our Safe and Calm webinars, we will just be holding them on Wednesdays, so we will no longer be having the webinars on Friday. So our next webinar will be January, I believe it would be the 13th at 10 a.m. So we will just be going on Wednesdays from now on. All right, so let me pull these questions up. Once we get through our initial vaccination of staff, I am concerned about vaccinations for future staff as we encounter turnover. What will be the method for getting vaccines for those new staff down the road?
I'm not sure that that's clearly identified. My understanding is it will not be will not be included in the pharmacy partnership program. We anticipate that people will be getting their vaccinations either through their local health department or through a nearby hospital, depending on the situation. We're not there yet. So how that's going to happen, we hope to get some guidance from MDHHS soon. But right now they're focusing on just getting the first run done.
Okay. You are including KN95 when you say N95 as well?
No, when I'm talking about N95s in especially the myosha guidance, and this is something that I'll be honest with you, I have tried to get some clarification about and have not fully yet. because our understanding in the FDA, if the FDA has approved a KN95, we thought that it was completely substitutable. But MIOSHA is saying no. And that's the piece that we're working to clarify. So I would suggest you go back through the MIOSHA slide and review what they're saying. But to be honest with you, it's not clear to us either at this point, and we're continuing to work with MIOSHA to get a specific, clear guide about what they expect here, because all of the rules for from each entity are different and conflicting.
Okay. Can you send out the guide from Laura that you mentioned gives surveyor guidance on the mask?
Sure, we can do that. We anticipate that we will be sending out a member update, and we will do that later in an attach.
Okay. At this point, it looks like that is the last question. So at this point, we would like to thank Dalton and Deanna, and we would like to thank all the members who joined us today to discuss everything going on with vaccines at their facilities. So now we would like to thank also our members and participants. I believe that we had 105 people that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. As always, you can always send an email over to the Safe and Calm Deanna or Dalton emails, and we will make sure that we get those questions answered for you. Other than that, I hope everyone has a great remainder of their Wednesday. Hopefully we see you at our Finance and Strategy Day tomorrow, and we will reconvene our next Safe and Calm webinar next Wednesday at 10 a.m. Thank you and have a great day.
Thank you, everyone. Take care.